Moving on now to vascular abnormalities that can occur within the brain. Berry aneurysms are one of the most common abnormalities of the vasculature. There are localized dilations of the vessels in the brain, produce these outpouchings right here, which can swell like a balloon and burst. Because of this, they're the most common cause of subarachnoid hemorrhage. They're associated with modifiable risk factors such as smoking, alcohol use, cocaine use, and hypertension, although there are a number of non-modifiable risk factors that can affect these as well, such as ethnicity, in particular in African Americans. They're more common in women, and they're more likely to occur in individuals with underlying conditions such as autosomal dominant polycystic kidney disease, in Ehlers-Danlos syndrome, or in coarctation of the aorta. Berry aneurysms present with subarachnoid hemorrhage, which we'll discuss in a bit, as well as sentinel headaches, which can warn of impending hemorrhage, and also with location-dependent cranial nerve deficits before there's hemorrhage. Berry aneurysms most commonly occur at branch points in the circle of Willis in the brain. The most common location is at the branch point between the anterior communicating artery and the anterior cerebral artery. When an aneurysm occurs here, it can compress the optic chiasm, sort of like a pituitary adenoma, and produce bitemporal hemianopsia. Berry aneurysms can also occur commonly at the ICA-MCA branch point and at the PCOM-Basilar branch points, where they may compress cranial nerve 3 and result in ipsilateral, same side, mydriasis eye dilation with the eye down and out. There are two major ways to diagnose intracerebral aneurysms. The first is catheter angiography. This is when a catheter is introduced through the femoral artery or through the radial artery, up through the aorta and into the cerebral arteries in order to inject contrast agents through the catheter and get detailed fluoroscopic images of the intracerebral arteries. Catheter angiography is the gold standard for diagnosis. However, it is invasive and has a small risk in about 1% of patients for producing small cholesterol embolisms with resulting stroke. Catheter angiography is CT angiography, or CTA. In CTA, contrast agents are injected peripherally, which allows for visualization of the cerebral vessels using a CT scan. This can be pretty easily obtained right after you obtain a non-con head CT in the ED for a patient with suspected subarachnoid hemorrhage. CTA is non-invasive and can be rapidly obtained. However, it does produce artifacts at the base of the skull where there may frequently be aneurysms, and it may miss small aneurysms less than 5 millimeters in size. There are two major ways to treat aneurysms. The first is surgical clipping, which is where a craniotomy is performed, opening the brain to surgical clipping of the aneurysm, closing it shut. This prevents it from rebleeding. The second is endovascular coiling. Like with angiography, a catheter is fed up through the vessels, through the aorta into the cranium, and a coil is inserted into the aneurysm and circled around. This clots off the blood present within the aneurysm and prevents further bleeding. The choice between coiling or clipping is normally decided by characteristics of the aneurysm, such as if the neck of the aneurysm is amenable for coiling, if the location of the aneurysm is such a place that the neurosurgeon is able to reach it for clipping, and if the patient can tolerate neurosurgery. There is some evidence now that subarachnoid hemorrhage may mean that the brain is more irritative and thus is less able to be safely treated by surgery, and thus coiling may be preferred. There is evidence that coiling is better for patients over 40 years if a patient is candidate for either clipping or coiling. However, it's less clear for patients under 40, where studies have shown about similar results. Currently, clipping is preferred for these patients, given that clipping has less risk of recurrence. Subarachnoid hemorrhage commonly presents as a sudden onset thunderclap headache. Patients often describe it as being the worst headache of their life and rate it as being 10 out of 10 pain. When this occurs, it's very fast onset. It can also result in a decreased level of consciousness, such as drowsiness or altered mentation, and it can also result in delayed meningeal signs occurring from the blood irritating the meninges. This results in findings such as nuchal rigidity, Brzezinski's sign, and Kernick's sign. The initial workup of subarachnoid hemorrhage is to obtain a non-contrast CT scan. This very easily picks up blood, which occurs bright on imaging. You can see here a classic example of a star that occurs at the base of the brain, occurring from blood filling up the basal cisterns and the sulci. Rarely, CT scans may be negative. If there's still high suspicion for subarachnoid hemorrhage, then it's important to obtain an LP. When you get an LP, you can see that there's high counts of red blood cells present on all taps, not just occurring at the very beginning when there might be a traumatic tap, but up until the fourth tube that you draw off. Or there may be xanthochromia, which occurs from breakdown products of hemoglobin. There are a number of complications associated with subarachnoid hemorrhage, in addition to the high risk of death in about half of patients. Subarachnoid hemorrhage due to aneurysms may rebleed, resulting in a second incidence of subarachnoid hemorrhage. Additionally, the blood in the CSF may block off reabsorption of the CSF, resulting in hydrocephalus. Blood may produce SiADH, which can cause hyponatremia. Blood may also irritate the surrounding vasculature in the brain, resulting in vasospasm, which can produce an ischemic stroke. Additionally, about 10% of patients will end up having seizures. Patients who have a subarachnoid hemorrhage are admitted to a neurological or neurosurgical intensive care unit where they can receive proper neurological monitoring for any changes in their neurologic status. This is important for monitoring for occurrence of rebleeding, hydrocephalus, and SiADH, which can also be monitored through obtaining serial BMPs. It's important to treat aneurysms within 24 hours of subarachnoid hemorrhage to reduce the risk of rebleeding. It's also important that before there's treatment of the aneurysm, that the systolic blood pressure is kept below 120 in order to reduce the risk of rebleeding. About 10% of patients have seizures, therefore we give anti-epileptic drugs for seizure prophylaxis. There's also evidence that nimodipine, a calcium channel blocker, can prevent the risk of cerebral vasospasm, reducing morbidity for these patients. Now moving on to vascular malformations that can occur inside the brain. Developmental venous anomalies are dilated veins that converge into a single transcortical draining vein, as seen here. They are usually an incidental finding, and the risk of hemorrhage is extremely low. Given this, treatment is not needed. Capillary telangiectasias are nests of dilated capillaries without smooth muscle and elastic fibers in their walls. They're associated with hereditary hemorrhagic telangiectasia, which is associated with telangiectasias located throughout the body. This is usually an incidental finding, and the risk of hemorrhage is extremely low. Therefore, treatment is also not needed. Cavernous malformations are vascular sinusoidal channels made up of endothelium. They lack intervening brain parenchyma and appear as popcorn on T2 MRI scans. The risk of hemorrhage is higher than for the other malformations we've discussed. If they are not symptomatic, then they're only observed. Surgery or laser therapy is performed if they result in seizures or if they have associated hemorrhage. Arteriovenous malformations are the malformations that we are most concerned about. They are dilated feeding arteries and arterialized draining veins inside dysplastic brain tissue. Given that the arterial system has much higher pressure than the venous system, having blood go directly from the arterial system to the venous system results in high pressure seen by the venous vasculature. Given this, they have a high risk of hemorrhage. 50% of patients with AVMs present with hemorrhage, while 20 to 40% present with a seizure. Given an overall high risk of hemorrhage per year at around 2 to 4%, and a high risk of death if hemorrhage occurs, then these are recommended to be treated. Treatment options include surgery, which has associated surgical risks, gamma knife therapy, which takes 2 to 3 years in order to be effective and thus has higher risk in the time that is taking effect, or embolization, which has an overall limited cure rate.